Lonnie is a seasoned healthcare leader who previously founded and owned a full service healthcare marketing agency before establishing Forefront Healthcare Consulting, where he leads a consortium of independent consultants serving healthcare providers, insurers, and self funded employers. As a co catalyst of Healthcare Reinvention Collaborative, Lonnie is dedicated to advancing proactive disease prevention and early intervention strategies to help people avoid and recover chronic disease. I reached out to Lonnie because I heard that he was doing something around Medicare, and he's going to tell you more about his work. And I'll turn it over to Lonnie.
Well, thank you, Dawn. Thanks for inviting me to share what I'm focused on and working on right now, which is actually the impending budget cuts to Medicaid and the massive impact it's going to have on all Americans, not just those who are currently receiving health care through Medicaid. I expect that many of the people here today already know a lot about what's going on as it pertains to threats to Medicaid, but let me share a bit more context just to be sure we're all on the same page. Medicaid cuts are coming. It's not official yet, and specifics of the cuts have yet to be determined, but funding and grant cuts will happen. The grant cuts are already happening. And my view, and that of some others that I coordinate with, is that just waiting for this inevitable shoe to drop is really irresponsible, as well as buying into a powerless victim mentality. Medicaid and CHIP, which is also at risk for cuts, cover healthcare for millions of Americans and not just those below the poverty line. For example, Medicaid covers 63% of all nursing home residents. And CHIP, which is the Children's Health Insurance Program, provides low-cost health coverage to children in families that earn too much money to qualify for Medicaid, but don't earn enough to really be able to provide the kind of health care coverage that their children require. So one of the more likely scenarios for these cuts to Medicaid funding is that the federal government will reduce its share of the funding of Medicaid expansion. Medicaid expansion, for those of you who may not be as familiar with it, began in 2014 under the ACA and today covers around 25 million people in the US, including adults earning up to 138% of the federal poverty level. So the expectation is that rather than simply ending the program, it's more likely that Congress will reduce its share of funding under Medicaid expansion from currently what its share is, which is 90%, to match the funding share for all other Medicaid beneficiaries, which across the country probably averages closer to 50%. And so the states will be left to decide how to make up that shortfall. Well, that likely means many people who are currently covered and qualify for Medicaid under Medicaid expansion will no longer be covered. In fact, there are 12 states in the US that already have trigger laws in place that would immediately shut down all services to those currently enrolled in Medicaid through Medicaid expansion, concurrent with a reduction in the percentage of funding by the federal government. Now, if you combine that with the risk, maybe more the likelihood of ACA's enhanced subsidies expiring at the end of this year without being renewed, that's millions more Americans who won't be able to afford health insurance at all. So where will they show up for care? Well, if they don't have to, they'll postpone, they'll defer. And if they do have to, they'll go to the nearest hospital emergency department that they can find for charitable care, which will increase waiting times dramatically for everyone. And the hospitals impacted by these cuts will respond by cutting staff, which will further increase waiting time and decrease access. And if you add to that the fear that many Medicaid recipients who are either undocumented or paranoid that they will be inaccurately miscategorized or will expose family members to additional risk, and who, as a result, will defer care as long as possible, many of those will also end up in emergency departments. Reliance, as has been the case, on governmental bodies to keep patients and providers informed has already been effectively interrupted. And many Medicaid beneficiaries are afraid, confused, lacking information, and have little reason to feel confident that public officials will do much, if anything, to protect them. Some of you may know that there was a town hall held last night in Scottsdale, Arizona, with Arizona Democratic Senators Mark Kelly and Ruben Gallego. And from what I could glean from the coverage of that meeting, the senators had few answers beyond encouraging citizens to make their voices heard. Access is the Medicaid program in Arizona, and it serves 2 million Arizonans, and over 500,000 of those are eligible for access only through Medicaid expansion. So you can see the impact even in a single state. Hospitals, skilled nursing facilities, and other safety net providers are going to have to cut staff, which affects all patients, not just Medicaid beneficiaries. And so it's the view of people that I'm working with right now that those who are in the safety net ecosystem really have to take ownership of their own strategic planning and communication strategies to patients, as well as to payers, to community advocacy organizations, and to other NGOs. In fact, there's a strong argument to be made right now that the window of opportunity to be proactive in outreach by safety net providers to Medicaid and CHIP beneficiaries is between now and the end of this year. Unfortunately, most of those constituents, most of the stakeholders who are doing any contingency planning are essentially doing it in their own private silos and thus in a relative information vacuum. And it's our belief that we can learn from and adopt best practices from each other and from groupthink. So there are a few people that I'm working with closely right now. Sally Mildren, who some of you know, is one of them. There's another gentleman named Michael Marchand, who until the beginning of this year was working in the Office of the Insurance Commissioner for Washington State. And we're working on developing a third-party, unbiased intermediary to connect these safety net stakeholders in more effective care coordination, collaboration, and communications with each other and to their constituents, rather than continuing to try to figure it out on their own. We're going to start with the Medicaid safety net provider organizations, talking to each other and learning from each other. And we're anticipating setting it up in a way that even if they don't feel comfortable sharing strategies with each other in a public forum, that we can provide a conduit so that they can share strategies and plans without attribution. And if they're willing to meet as a group in virtual public settings, so much better. Once we establish a foothold there with the provider organizations, that would include hospitals, critical access hospitals, rural health, free federally qualified health centers, and other organizations that provide healthcare services to a disproportionately high number of Medicaid recipients. We're expanding that circle, and we intend to include Medicaid managed care organizations, the insurers that are more heavily committed to Medicaid, as well as state Medicaid agencies and community NGOs. So with that in mind, as it goes to how can you help? Well, we're going to start with a focus on the state of Washington, where Sally and Michael and I already have some connections and experience, and we know that there are others, some others at least, who are involved with HRC that are also pretty well connected in Washington State. But it's essentially where the pilot of this effort will be set up. And we need contacts and introductions at this point to C-suite executives in rural hospitals, critical access hospitals, FQHCs, as well as some executives in larger urban hospitals who are also going to feel the effects of Medicaid cuts in their emergency departments, preferably if anybody has those contacts in Washington State, where we might not, and could arrange any introductions that would be extremely valuable. Our goal is to expand this effort to other states, but we first need to prove to the safety net ecosystem stakeholders and, frankly, to ourselves that this is possible, which is why we're starting with Washington first. So we're happy to engage with these individuals privately or in small group discussions if they're willing to share in that kind of forum. I know that part of this discussion is also what we can offer to HRC and its members. And I would just say for me personally, as somebody who's had a long history in communications and marketing, I would be able to help where I can in providing ongoing communication support for people in HRC who are trying to get their message out. I've got a pretty good network, particularly on LinkedIn, and so networking and introductions where I can be helpful is something I certainly would want to offer to anybody in the HRC network. Also maybe some marketing guidance if some of the efforts that some of the HRC members are working on could benefit from some of what I've had in terms of my experience over 35 years in marketing and communications, specifically in and around the healthcare industry. I'm happy to have those conversations as well, and appreciate everybody's time and being able to be here today.